Welcome to the Center for Innovation in Campus Mental Health's Conversations Over Coffee video series. My name is Perlin, and I am the Research and Knowledge Exchange Coordinator for the Center. Joining us today is Meg Houghton from Humber College. Hi, Meg. Thanks for coming in.
Hi, thank you.
So, Meg Houghton is the Director of Student Access, Wellness, and Development at Humber College. And today we're going to be talking about integrated care on campus. Or in other words, the idea of having a centralized location where students can go to for all their well-being needs. Meg here has been heading up a strategy to provide integrated health, counseling, and accessibility services on her campus. So tell us a little bit about what is the model of integrated services at Humber College.
Great, thank you. So for the last 3 years, we have had 2 centers at Humber College running integrated health, counseling, and accessible learning services. On most campuses, you'll find that these services are not integrated. They operate separately, report to separate directors with their own budgets. Often with, a whole bunch of space between their locations on campuses. And so the idea behind integrated care is looking at ultimately what the end user needs and building your service model out from there. So what we know about post-secondary student mental health needs is that there are significant barriers to access in the first place.
Yes.
And then from the point of first contact forward, it can be very difficult for students to get the subsequent supports that they need. So there's a lot of research around the idea that, to support the idea that even from the point of seeing a physician forward, the recommendations around additional behavioral support or accommodation have very little uptake by students in a non-integrated model. So what we were trying to accomplish here was reducing barriers to access both on the front end, and we found that there's a reduction of stigma just in having co-located services. So students could be at our center for any reason at all. If they see somebody in there, they could say, I'm here to get a cough medication. And so there's sort of a lovely upfront reduction of stigma in a combined service environment. And then from that point forward, what we're seeing in our stats and research is that there is significant uptake in complementary services from physicians to behavioral support with psychotherapists, through accommodation support with accessible learning services. And that's enormously important because when you consider for anybody the time it takes from initial symptoms to medication, treatment, support, it can be a very long pathway. And so this integrated model is really intended to expedite the access to necessary services, ideally so that we have a reduction of symptoms as soon as possible. And what that means for the student is that the likelihood that they will succeed academically is that much higher, right? So, you hear stories about people from the onset of symptoms through diagnosis. That alone can be, a 6-month to a year journey. And then as it relates to mental health being diagnosable, I still think that there's an enormous barrier there for folks to understand. Even just, when you get a diagnosis, that in and of itself is a big thing to wrap your head around and to contemplate and to understand. But then to make the leap from that through to understanding that may be an accommodatable disability is another major hurdle and potentially a barrier for that student. And so it is something that we can do really well in an integrated environment is look right up front at what those functional limitations are that a student's experiencing, and with great ease put the accommodations in place, ideally improving outcomes not just from a mental health perspective but from an academic perspective as well.
That is amazing. So is there a shared vision between the 3 different departments that were integrated together in terms of supporting students?
Yeah, well, it started with a simple vision, I'd say, and I don't think that we are or certainly we were, at the time of integration, we were not unlike any other campus mental health service. Or campus health service, or campus accommodation service, in that each shop did its own respective thing to support students, and thought about their reason for being as providing that thing. And so part of the work of integrating services was really taking a more deliberate and holistic view of what students need and how our services could work together to facilitate those needs. And when you dig into the research, I think it becomes abundantly clear what the end user or the student might need, and how an integrated environment might better suit those needs. And so I think my team was quite excited to begin to look at how they could work out of their respective silos to support the broader needs of the students, recognizing that an interdisciplinary approach was going to produce the strongest results for students.
Right. So does that mean that there's a lot of crosstalk between the departments? Is it something that's formalized, there's a protocol in place, or is it just very casual that people are just working together and it's one big happy family?
Yeah, so I think that these are the questions that become really complex around integrated models, because technically we have teams working under two specific pieces of legislation, PHIPA and FIPA, for our accessible learning services team, and then obviously our regulated health professionals are working under the Personal Health and Information Privacy Act, which has obviously a higher threshold around privacy. When students come to our service, they sign off on a confidentiality form that indicates that they understand that we will be exchanging information within our service in a manner that is reasonable and necessary to facilitate their needs according to their consent. And it's really from that point forward that discretion and consideration and conversation around what the student needs drives the exchange between practitioners. So there would be very little need, particularly in the new environment around functional limitation versus diagnosis. There'd be very little need even for a practitioner to share a specific diagnosis with our accommodation staff. The information that needs to be exchanged in order to accommodate students is really about functional limitation.
Right.
And our practitioners are, bound by the ethics of their own professional colleges, and quite rigorous at limiting the information exchanged for specific purposes. And I'd say that all of that is happening within an environment of trust and dialogue, and that is a really critical pillar in building an integrated environment. And without that, people tend to, close off and return to more siloed practice. So it was really critical for me and for Humber College as the custodian of our records to establish up front what the legal parameter was around consent, given that we're the custodian of the records. But then from that point forward, to create a lot of space for practitioners to determine within their own practices what was appropriate and reasonable and ethical in accordance with their own colleges.
Right. So do you feel like there's been a shift in the culture of communication between and within the department? So for example, prior to this, when people are working in silos, this is the culture in their department. But now that, say, the accessibility people and the counseling people are working together, is there some sort of change in culture?
Yeah, I think so. And what we're doing is, just encouraging, some baseline behaviors around consultation and support. So, we've created a common consult hour in everyone's schedules. We have a common staff fridge
Okay.
and microwave, which can't be underestimated in terms of, encouraging people to show up at the same.
Absolutely.
Yeah. We have common staff retreats. I communicate out to the entire team all at once, so there's no distinction in how I communicate out to people. We talk about the broad objectives of our service as much as we talk about the more finite deliverables within each functional area. And so I think we've attempted to set up a culture of that sort of supports the more organic consultation and connection.
Right.
When we first opened, we bought a coffee card and encouraged people to go out and have a consultation on the office with somebody from another functional. So little things like that. We're doing common professional development on an annual basis, looking at the professional development areas that are of common concern. So, some of the things that we've taken up over the last year was compassion fatigue. We looked at mental health and the effect of stress on learning from a neurological perspective, what actually happens in the brain. So these are the kinds of topics that we're using to draw in our entire team from each of the 3 functional areas. And so far it seems to be having good effect. These are slow-moving efforts, right? Creating a culture.
Right.
But it really is through that, through those more organic relationships that you see trust being built. You see practitioners seeing benefit in broadening their practice and working in an interdisciplinary way with colleagues. And this has been particularly important and effective around complex cases. I think minimizing the resources required to support a student, and I think it's been enhancing for individuals to be able to work side by side to identify what an individual with complex needs would benefit from, and then to set out a joint plan together. And this environment around integration is just ideal for that sort of collaboration and connection.
Yeah, it sounds like you've been working really hard to build that background of trust and support between people, because it's not enough to just dump people together like, hey, stop working in silos, you can all work together now. But building that culture of trust is really important.
Absolutely, and the common interest among anyone doing this kind of work is improving outcomes for their patient or their student, right?
Yes.
And so that's the notion that drives all of our conversation. How do we improve quality and outcomes for students who need our support? And then drawing the linkages between our services to that goal. So we've just now this year found that 42% of students who went to see a physician for a mental health related visit have used all 3 services. And that is, those are the kinds of stats that we use to go back to our team and say, this is what's working. Now let's look at the specific outcomes for those students who accessed at a very high level versus students who did not. And so we're attempting to ensure that we're not just taking a warm and fuzzy approach to what we're doing here, but we're building an evidence framework around the integrated model that helps to support each practitioner in understanding the deep value and the actual outcomes for students at the end of the day in an integrated environment.
Yeah. So from an administrative perspective, why does it make sense to have a model of integrated care on campus?
Well, I think most of us have, let's put it this way, all of us would like to have more resources.
Of course.
So
it's number one on the wish list, always.
Yeah, and so anytime you can look at bringing together multiple budgets, you know, there are clear advantages to that, getting to do more from a professional development perspective. In this case, integrating into one location enabled us to save a little bit on staffing at our front desks. Not as much as we thought we would, because what happens when you co-locate is that you get busier.
Of course.
And I think, you know, one of the strategic benefits is tucking in services that within a post-secondary environment are seen as not necessarily core business, being health and counseling. Tucking those services in with a legislative requirement around accommodation makes good sense, and it makes as much budgetary and strategic sense, I think, as it does good sense for student outcomes.
So on the other hand, what do you feel like are some of the inefficiencies that arise from not having a model of integrated care?
From not having a
Yeah,
model?
from not having.
Oh,
So like in the past or
yeah.
potentially in the future.
Well, it's you know, from my perspective, it's opportunity lost, and so just through a professional lens, it's opportunity lost, because what we know around mental health is that a lot of folks on our campuses are having the same conversations but in isolation.
Right. And
so this model really brings practitioners together to contemplate what is a complex terrain together. So I think, you know, in non-integrated models, that's just an opportunity lost. But the real it's not, you know, it's not a, sorry, I'm at a loss for words, but it really is what it does for students to need to traverse across campuses, tell their story multiple times, introduce themselves to multiple practitioners at a point where potentially they're feeling quite poorly. I like the notion, and I use the term transactional friction. I think we can underestimate the effect of some of those small steps, and we perceive them as small from a place of wellness.
Right.
But when you're new to a post-secondary environment, you're feeling unwell, maybe you're feeling like you've got more precarious social support, more precarious financing, maybe you're lacking motivation on top of experiencing some mental health related symptoms. It really doesn't take that much to create a barrier to service access.
Yes.
And so I really think that the integrated environment is intended to maximize the likelihood of uptake on services that we know are reducing of symptoms and produce positive academic outcomes for students. And in less than integrated environments, I think we have a tendency to see students fall off by the wayside in ways that we may not ever really detect or be able to measure. You know, there are some estimates that roughly 50% of early dropouts in the post-secondary environment relate to mental health. We're lacking really good data around that, but you know, that kind of data does make you scratch your head and wonder, well, what else could we do to encourage service use, to reinforce students and to keep them in school? And I think the integrated environment is uniquely situated to do that.
Yeah. The more steps you have in the system, the more opportunities there is to lose someone in one of those steps.
Absolutely, yeah.
And speaking of steps, we've heard that you plan to assimilate the step care model onto your campus as well in conjunction with integrated care. How do you see that panning out?
Yeah, so I think that there is a trend in the system right now, in the post-secondary system, where we have, it's actually two simultaneous trends. One trend is quite positive and a result of stigma reduction. where we are seeing far greater number of students who are interested in seeking counseling, but who may in fact have low-grade needs for support that might be a little bit more developmental or transitionary or adjusting to heightened levels of stress in the post-secondary environment. But generally people who are not presenting at a clinically concerning level. And then simultaneously we're seeing, I think most directors in the system would agree, we are seeing a far greater number of complex case presentations, students who may require multiple practitioners, psychiatric support, community-based support, while pursuing their educational goals. And so the net effect of those two trends happening simultaneously is that there is an enormous demand on our counseling services. And for most of us, that day when you could provide an hour-long session for anyone who came to the door indicating that they wanted to speak to a counselor is really a thing of the past. And so for many of us, the decision to look at stepped care or stepped care-like models has been forced by limited resources. But I think that there's also a real benefit to looking at a model that is strengths-based. Not every student that comes to us requires a deep therapeutic or medical response. And so it is looking at what students need, where they're presenting on the spectrum between flourishing and languishing, and then providing them with a level of support that's appropriate to their presentation at that juncture. But also, recognizing that mental health is fluid and opening the door for students to return to us at any point that they need a higher level or a lower level of care is where we're going with a stepped care approach. And I like the idea that it works from a strengths-based model. I think, there's a lot of talk about student resilience. And we are seeing students who are enormously resilient. And I think particularly in the college system, we're seeing students who have very precarious social determinants of health who are showing a great deal of resilience just by coming to campus. And so in a strengths-based stepped care model, we're really looking at what somebody has in place already from a coping and adaptation and a resource perspective, and maybe in some cases providing some encouragement, care, and support and to build off of that base. And in other cases, we will see students who require, maybe the full slate of our services in an integrated environment, but the stepped care model at least provides that upfront assessment so that we're better able to create a plan that corresponds to each individual student need.
I do feel that Humber College and any of the other colleges and universities who have an integrated care model at their campus are uniquely positioned to really take advantage of the stepped care model, simply because in the stepped care model you need to use resources which are sometimes not necessarily within the counseling department. So I do feel like it's a great decision to take that on.
Yeah, absolutely. We have mental health nurses who can do an extraordinary amount of work around de-escalating and skill building and supporting baseline pro-social and coping skills. And so in a stepped care model, our nurses, GPs, psychotherapists, and accommodation specialists all get woven into the potential pathways, to say nothing of the other services that exist within student affairs, right? Like if we're taking a full social determinants of health perspective here, Then our partners in residence have a role to play. Our partners who are running peer mentoring, our partners who are running academic support on campus, they're also a part of that, that broader net of support that's available to students. And so, I think that there are sort of concentric layers or levels of support available to students that we already have a little bit of practice in contemplating within an integrated model. Sort of asking those bigger questions around what else might be supporting or reinforcing to this person, and how do we sort of create a little bit more of a wraparound for individuals who might benefit from that, but then thinking, again, like I said, more broadly at what else is available and how do we partner with our other resources on campus to facilitate the best outcomes for students.
So something that was touched on really briefly before was in talking about how wait times are increasing and like counselors may be feeling more of that burden. So this might just be conjecture, but I'm thinking that there might be some burnout, like professional burnout. Do you think that the integrated care model helps with that sense of burnout? Because we're also seeing that there's a culture of shared responsibility with other professionals in other departments. So what do you think?
Yeah, I think so. So the research on this shows that in the broader health community, practitioners working in an integrated model or a coordinated care model seem to benefit from a professional development, from a collegiality, and almost from a variety, workplace variety perspective. And so I think that there are benefits there, and I think that that's bearing out in the research from the broader health system. Certainly in the stepped care model, there is research to support the idea that for psychotherapists in particular, doing the hour after hour of client-based sessions all day can reduce overall satisfaction and can lend itself to burnout by virtue of lack of variety and sometimes around case intensity. And you have to wonder too if maybe practitioner isolation plays into that. And so in a step care model, what we're looking at is by virtue of, potentially seeing more students in a day, but who maybe require less intensive intervention. Just by virtue of that model, you get a little more variety of appointment, of conversation, of therapeutic intervention among practitioners. So I think that the combination of stepped care and integration is likely to produce higher job satisfaction, higher morale, and ideally, and when you need well practitioners to support student wellness, right?
Exactly.
Something that we forget about and don't talk about enough. But the ideal is that our practitioners are also feeling like they are thriving in their jobs, which are complex and can be stressful.
Yeah. So what has been the student experience so far? Do you have any stories to share of students who come in and they leave and it's great?
Yeah, so, I think we rely on anecdote maybe a little bit too much, but there is a place for stories. So if I can start from the stats, we're seeing really strong uptake in broad support. So students who are seeking mental health support from physicians, psychotherapists, and our accessible learning services consultants. That accounts for 42% of students who've seen a GP for mental health. And so we're quite pleased with that. From there, if we look at who's seeing a physician and then going for accommodation support, that accounts for 26% of students who've seen a GP for mental health related support. And the proportion of students who've seen a GP and a counselor accounts for 16% of the total students who've seen a GP for mental health. And so that's really interesting. And I'm struck that a greater number of students are seeking GP support and accommodation support than GP plus counseling, because there is a strong lean in the system toward integrating health and counseling, and the accessibility piece is often left out, largely because of concerns and preoccupations around the legislative piece, the privacy piece. But once you've cut through that, we're beginning to see that there is real interest in our students from the point of seeing a GP to straddling back in for accommodation support in the classroom, ideally to reduce the impact of functional limitations, right? So that's great. I have to say, this year with the sexual assault, sexual violence legislation coming through, there is a requirement in that legislation that we look at how we are going to accommodate students who require support after an assault. And the term accommodation is sort of fluid in our environments, and we're trying to figure out where the best place is on most campuses to accommodate students who've had a recent trauma. And so in an integrated environment, what we've seen is students who've had a initial contact, either with health or counseling, are better able to get the support they need. If there are long-term impacts, long-term functional limitations, they're able to get that support through our accommodation support service. But they're also able to get preliminary support through our health and counseling team in getting support in a confidential way from their faculty. I'd say we also have seen some surprising outcomes around complex cases for who ends up being the case lead. Oh. So we had a student recently who had a very complex presentation, was a first-generation Canadian, had a history of trauma, and a disability that impacted his in-class behavior. And that student ended up connecting with our nursing team, our psychologist, and our accommodation staff, and ultimately built the strongest therapeutic alliance, if you will, with a non-therapist, with their accommodation case lead. And so given that individual student's tendency to want to see her and her alone, the rest of the care team capitalized on that, and she became the case lead. Wow. And so it was interesting to see that we could accomplish significant outcomes and provide meaningful support for that student that likely had a clinically significant impact, but using an overtly non-clinical approach. So yeah.
Well, whatever works.
Yeah, whatever works. Absolutely. And so that's an example of, unanticipated pathways that actually created great results for the individual student.
Yeah. So it really appears that having a model of integrated care, it benefits students, it benefits staff, it benefits the campus as a whole. It's organized, it's efficient, and it has addressed some of the gaps in service delivery in the past. It's great.
Yeah.
Sounds great.
Yeah. I mean, we all have everyone's working through their own things in their own respective organizations. We're not living a utopian.
Oh, of course.
but we're feeling very encouraged by some of the early indicators within the integrated environment, and we're excited to build out from that and to do further research on what's working and not working for students, so that we can continue to enhance their experience of care and accommodation.
Yeah. Amazing. Well, thank you so much, Meg, for joining us today.
Yeah, thanks for the
And-
coffee.
Yes, I hope you like the coffee,
I did.
and I hope yourself some treats. Well, if you'd like to see more of this, subscribe to our newsletter by going to our website, campusmentalhealth.ca, and leaving your email on the front page. If you're interested in other kinds of resources, news, or ideas about post-secondary mental health, please go to our website because all of that and more is also available there. Thanks for watching.